Okay, so good morning, everybody. And it is indeed a pleasure to invite all of you for the second day of the Advanced Pediatric Endocrine Symposium. And we are starting right at 8 o'clock. It's very early. And we hope to have many more academic enriching sessions and try to cover those topics in that perspective. So this is going to be another interesting session. We'll start off with the case conundrum session, in which we'll have very interesting 7 cases. Followed by, we'll have discussion on the state of art with regards to the long-acting growth hormone therapy beyond GHD, novel treatment in terms of GH options. Along with that, we'll discuss about the adolescent endocrinology and adolescent gynecology aspects. Then we have a session on calcium and bone, in which we'll try to cover about refractory rickets, hypo and hyperparathyroidism, and low bone mass. And finally, a very interesting grand round on testes. So it's going to be a very interesting scenario to begin with. So we will not spare any further time, and we'll like to start the presentation. And in the beginning, so this is going to be the case conundrum session. Do we have the chairpersons here yet? So we'll start with the case conundrum session. And I would like to invite the first presentation, which will be done by Dr. Bifina Begum, who is the assistant professor in pediatrics at Government Medical College, Ernakulam. And she'll be talking about a very interesting case of non-autoimmune type 1 diabetes.
Good morning, all, and thank you, sir, for this chance. I'll be presenting a case of non-autoimmune insulin-dependent diabetes mellitus. I don't know how to do. So we had in our diabetic clinic a 9-year-old boy known to have diabetes since 4 years of age, and he was on insulin, basal bolus regime, and he was found to have decrease in vision. So routinely also ISPAD guidelines recommend ophthal evaluation at 11 years for diabetes mellitus at 11 years of age or 2 to 5 years after diagnosis. But he had a decrease in vision also. So we went forward with the ophthal evaluation, which showed a bilateral temporal cataract. So they suggested MRI, which showed bilateral thinning of optic nerves. We also proceeded with the hearing evaluation, which showed a mild bilateral sensory neural hearing loss. So since both vision and hearing were affected, we were thinking of, as you all heard yesterday, this Wolfram syndrome or DID-MOD. The components of Wolfram syndrome is in DID-MOD, that is diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. So since this confirmation is through genetic study, we discussed with the parents regarding need for genetic study, but at the time they were not affording. So we kept him under follow-up for any evolving signs of diabetes insipidus. But this is clinically difficult as both diabetes mellitus and diabetes insipidus have polyuria with polydipsia. But the difference is in diabetes mellitus, the polyuria is due to osmotic diuresis. So it will be associated with increased serum osmolality due to high blood sugars, will be associated with increased urine osmolality also. In diabetes insipidus, the polyuria during increased serum osmolality, the urine osmolality will be decreased. So this is his sensory neural hearing evaluation, which showed bilateral sensory neural hearing loss. So we went forward with the lab evaluation because genetic test could not be done at the time also. And his serum osmolality showed it was increased at 303 milliosmoles per kg. And serum sodium at the time was 140. And simultaneous urine osmolality was very low at 178 milliosmoles per kg, and urine sodium was 61. So the criteria for diabetes insipidus is when the serum osmolality is more than 300 milliosmoles per kg, the simultaneous urine osmolality will be less than 800 milliosmoles per kg. Here, his was very low at 170 milliosmoles per kg. So the diabetes insipidus was confirmed, and he was started on oral desmopressin also. Then after that, we proceeded with the genetic test, which confirmed our diagnosis. The clinical exome showed a mutation in WFS1 gene at exon 8, and which was Wolfram syndrome 1. So some few words about Wolfram syndrome. It's a rare genetic disorder Actually, reports show that 1 in 50 lakh or something. And it is autosomal recessive inheritance usually. And the components are, as I already said, diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. So this insulin-dependent IDDM is non-autoimmune. And this is the first manifestation typically, which occurs around 6 years, followed by optic nerve atrophy around 11 years of age, manifested as loss of peripheral vision and color vision. In 65%, there will be sensory neural hearing loss and central diabetes insipidus in 70% in the second decade. Then other abnormalities are urinary tract abnormalities in 60 to 90%, which manifests as neurogenic bladder, atonic bladder, hydroureteronephrosis, recurrent UTI, usually occurs in the third decade. Then progressive neurologic difficulties in the form of ataxia, brainstem atrophy, which is progressive, mood disorders in 60% children by fourth decade. And the genetics is, in majority, the mutation is in the WFS1 gene or the Wolframin gene, but a minority have mutation in the WFS2 gene also. But here there will not be diabetes insipidus. Usually only early onset optic atrophy, diabetes mellitus, and deafness. This has a poor prognosis with premature death around 30 years of age and severe neurologic disabilities. Death is usually due to central apnea due to brainstem atrophy. And earlier it was considered due to mitochondrial disorder, but now it is a prototype of endoplasmic reticulum disease. There is currently no effective treatment to delay or halt or reverse disease progression, but so many novel therapeutic research is ongoing, and hopefully we'll have a cure for this. So the take-home message is, we have to think of Wolfram syndrome in children with diabetes mellitus and visual or hearing abnormalities. Diabetes insipidus in Wolfram's can manifest in the first decade itself. So we have to watch out for polyuria with low urine osmolality. It is low urine osmolality despite high blood sugars.
Thanks a lot, Dr. Bifna. Please stay there. I think this was a very interesting case. And what this case tells us is that whatever you read in books, often there are certain changes which will be there, which may happen in the manifestations. The children don't follow, the genes do not follow the books. I think that's the message from there. So whenever you have any child who has a you won't do an autoimmune workup in everybody. So if you have a child with type 1 diabetes with early onset visual symptoms, I think that would be the big message which is coming out of it. Dr. Hemchand, you have any experience about this condition? You like to share your...
Thank you, sir. I think just a couple of questions. Did you do an MRI of this baby?
Yes, sir. MRI was done, and that MRI showed bilateral thinning of the optic nerves, which is very sensitive for this.
Okay.
So
I think on a practical note, some people say is whether we can do an ADH level at the time of this, although cost is a big factor and the assay is a big issue, but that will give you some more confidence to push desmopressin into this child.
Yeah, because it's a very difficult issue in terms of whether it's a diabetes mellitus or insipidus. Copeptin or ADH will be a good way to go forward. I think that is it.
And the third point is regarding this, you very beautifully mentioned about associated urinary tract abnormalities. That is another, icing to the cake, because they sometimes have VUR and all that. That adds to a third component of nephrogenic DI also in them. So you have DM, CDI, and nephrogenic DI, all three in the same child. I think only trial and error, keeping a close watch on the child is the...
I think that's very good. So thank you, Dr. Bifina. So we now welcome our chairpersons of the day, Dr. Vikrant, who is the head of department at Mayo Medical College in Lucknow, and Dr. Vijay Jaiswal, who is the head of department at Meerut Medical College, LRM Medical College. So we are continuing now with our case sessions. The next session, which the next talk is on another very interesting manifestation, a rare but a very life-threatening manifestation of a common disorder. So for that, we have got Dr. Anusha. Dr. Anusha Reddy is working in the 7 Air Force Hospital, and she will be presenting this very, very interesting case. And Dr. Anusha is a squadron leader in the Air Force. So please go ahead.
Good morning, everyone. Today, I'm going to talk about a case of a 11-year-old girl, 27 kg by weight, daughter of a serving soldier who was a resident of Kanpur, who presented with sudden onset of, the girl was apparently all right the previous night. She had gone to a local fair where she had something, consumed something and slept. And as soon as she woke up in the morning, she had some epigastric discomfort followed by vomiting. And after that, there was rapidly progressive weakness of her body, like she was unable to move her limbs, and there was rapid deterioration in her level of consciousness. In such cases, as we all know, commonly we would think of trauma first, if there is any history, and followed by other non-traumatic causes like infections, metabolic, vascular, immune, malignancies, toxins, and bites. As I already mentioned, she was apparently all right the previous night. She woke up in the morning with multiple episodes of vomiting. And the vomiting was as such, it was non-bilious, contained normal food particles initially and water thereafter. Regarding the weakness, it involved all the 4 limbs. It was bilaterally symmetrical and it was gradually progressive. It was neither ascending as in GB syndrome. It was involving all the 4 limbs equally. En route, because of these complaints, the parents started moving to the hospital. En route, she developed stiffening of all 4 limbs. Basically, she had a form of GTCS. There was no history of urinary or stool incontinence. There was no tongue bite. There was no history of trauma. There was no history of fever, headache, loose stools, or rashes. There was no history suggestive of any bites. And there was no history of any particular drug or toxin ingestion. In this case, there is a very interesting past history. This girl was 11-year-old. Her younger sibling, another girl child, a 9-year-old girl, had presented to our own hospital 1 year back with similar presentation. And on evaluation, she showed ADEM, acute disseminating encephalomyelitis. But regarding this girl, there was no past history is not significant. The antenatal birth history is uneventful. And she is a developmentally normal child with a very good scholastic performance at school. This is the family history. The 9-year-old sibling of this girl had ADEM. Initially, as she was brought to emergency, she was given midazolam nasal spray in the emergency room, and followed which she had repeated seizures for which she was given IV midazolam. Her sugars, electrolytes, CBC, renal function test, liver function test, and ECG done by the duty doctor then was normal. On examination, as soon as I arrived, her vitals were temperature was 98°F, pulse was 122, respiratory rate was 22, BP was stable. Her SpO2 was 98%, but it was on oxygen with face mask. There was a very evident swelling on the anterior aspect of her neck. And on asking, the parents gave a history that the swelling was acute in onset, and they had noticed the swelling only over the previous night or this morning. On CNS examination, the girl was unresponsive. Her pupils were sluggishly reactive. There was generalized hypotonia throughout the body. Her deep tendon reflexes were absent and plantars were neutral. Other systemic examination was unremarkable. We had planned for MRI of this child, considering I already knew that the younger sibling had ADEM and this girl also had a similar presentation. So I had planned for an MRI, but on the en route to MRI, she started having desaturation. Her airway started getting compromised. So the plan of MRI was terminated and the girl was shifted to ICU. En route ICU, she rapidly collapsed. There was no pulse. There were pupils were non-reactive. So immediately CPR was initiated and she was intubated. And after successful resuscitation, she was put on mechanical ventilation. Over the period of next 48 hours, all the reflexes were lost, including the brainstem reflexes. Even doll's eye was absent. So in such a scenario, especially in this belt of the country, the first thing that we would think of is meningoencephalitis, especially viral meningoencephalitis, like Japanese encephalitis being very rampant in this part of the country. Apart from that, we had thought of autoimmune encephalitis and ADEM, considering the family history, and GB syndrome, considering the acute onset of weakness, snake bite, and drug and toxin intoxication. But last two things were ruled out as there was no history suggesting of these. Multiple sclerosis also was a possibility. Even in the previous child, we had kept her under follow-up. But then the girl had had an unfortunate death on table while closure of her tracheostomy, when she was referred to a higher center for closure of the tracheostomy. And the last differential that we had thought of was because it is very rare, an entity called Hashimoto's encephalitis, because of the swelling in the anterior aspect of the neck. Management, I'll come to it later. So the next thing that I did on the same day was a CSF analysis, in which proteins were markedly elevated, sugars were normal, there was no pleocytosis, there were no cells in the CSF, viral and bacterial PCR was normal, and CSF autoimmune panel was sent, which was normal. Apart from that, the CSF was totally sterile. There was on gram stain and culture, there was no organism was grown. So in this, there was basically, as we say, there was albuminocytological dissociation. But the nature of the weakness was not like in GB syndrome, like it was not an ascending type of weakness. And there were seizures which are not commonly seen in a case of GB syndrome. MRI brain of this child was done on day 3 when she was stabilized on ventilator. Which showed non-specific changes of a possible small SDH, which she had probably got because of a small fall or something during her seizure. And there were prominent optic nerve sheaths. Other than that, there was no significant finding on the MRI. Ultrasound of the neck was done bedside in the ICU, which showed features suggestive of thyroiditis. And FNAC of the thyroid gland showed lymphocytic thyroiditis. So this made me think on the lines of that there is something, definitely some autoimmune phenomenon going on. And the thyroid profile of the child was done. TSH was 181 elevated, T3 was 102, and T4 was 2.73, which is low. Thinking on the lines of autoimmune phenomenon, I sent thyroid autoantibodies, which were markedly elevated. So this moved the diagnosis of Hashimoto's thyroiditis higher up the ladder. So thereafter, we started immunomodulation. I started giving, along with other cocktail of autoimmune encephalitis that we commonly start, along with acyclovir, antibiotics. I started with IVIG 2 gram per kg, which was given over 2 days. Apart from that, I started high dose methylprednisolone at the rate of 30 mg per kg per day, along with thyroid supplementation of L-troxin 100 mics per day. So these were the differentials that I considered, but the investigations were pointing in the direction of Hashimoto's encephalopathy. So I continued the same treatment. By day 5, the girl developed ventilator-associated pneumonia. So the antibiotics were upgraded, antifungals were added. By day 9, she started showing improvement. There was spontaneous eye opening. She regained awareness by day 12. By day 14, there was motor movement had begun. By day 9 to 12, we started giving a spontaneous breathing trial, but which was not successful because of poor respiratory effort. On day 14, she was tracheostomized for the requirement of prolonged ventilation. Slowly and gradually with the same treatment, the methylpred was stopped on day 5, and I began with prednisolone at the rate of 2 mg per kg per day. And thereafter, she started responding to the steroids and immunomodulation. By day 20, the spontaneous breathing trial started showing response. And by day 22, the girl was weaned off from mechanical ventilator and placed on TPs. On day 26, she was shifted back to pediatric ward on tapering doses of steroids, anti-epileptic drugs, thyroxine, calcium, and D3 supplementation. By day 38, she was able to walk with support. By day 44, she was decannulated and tracheostomy closure was done. So after 2 months of hospital stay, almost a month in the ICU, she was finally discharged with the diagnosis of Hashimoto's encephalopathy, which is also known as steroid responsive encephalopathy associated with autoimmune thyroiditis. We had we had referred her to a neuro center, that is Army Hospital R&R in Delhi, where the MRI was repeated, CSF also repeated, and genetic testing is planned. MRI brain was again unremarkable. This was basically done to look for, because basically this entity called Hashimoto encephalopathy is sometimes considered to be a same spectrum of ADEM and multiple sclerosis. So the repeat MRI brain was done, but it did not show anything remarkable. CSF was again sterile, and autoantibodies still persist to be elevated. So what is this Hashimoto's encephalopathy, also known as steroid responsive encephalopathy with autoimmune thyroiditis? What are the criteria? Any case of unexplained encephalopathy, wherein you have ruled out infectious causes, wherein you have ruled out autoimmune causes, and where there is subclinical or overt thyroid disease with no specific MRI findings, with elevated thyroid autoantibodies, you should think of this rare but existent cause of encephalopathy known as Hashimoto's encephalopathy. So with the help of the entire team of 7 Air Force Hospital, we could manage this child and discharge her walking out of the hospital by 2 months. Thank you.
Very, very interesting case. We'll take some inputs from the chairpersons first.
Well, it was a wonderful case, and the way you proceeded with the case was also very remarkable. I would like to share some of, I've seen a couple of cases of Hashimoto encephalopathy. This is also a type of autoimmune encephalitis only.
Sure.
And MRI usually tends to be normal in this. But the way this child has presented, it looks more like acute necrotizing encephalopathy sort of thing. Because early in the morning, the child getting up within such a short span of time, she is getting comatose and all those things. But I'm surprised to know that thalamus and all those things were not involved.
Yes.
But most likely this was a case of autoimmune encephalitis,
Yes.
Hashimoto's
So
only.
what we need to understand is that many people think that it is hypothyroidism which is causing the problem. Hypothyroidism is just associated.
It is the antibodies
more
that
like
are the
an
trigger.
autoimmune process, and that's why the steroids, IVIG, that's what the best thing was, that it was started at the right time. And I think this was a wonderful example. I think we need to give a 3 big cheers to Dr. Anusha and the team. It was a wonderful case. She did discuss the case initially, and it was a very, very interesting
Most of the times, these thyroid functions come out to be normal only,
Yes.
but it is the severe high,
Yes.
really, the
Antibodies,
titer it persists, antibody titer it persists. So that is
I
the
think
big
that's
home
the
message,
biggest
that
message that
autoimmune encephalitis has to be thought of in all the cases of altersensorium, because it is a potentially treatable cause. The one cause where we can, if we hit hard, if we hit early, then the results can be absolutely different. Thank you.
Thanks a lot, Dr. Anusha. for the-
Thank you, sir.
Yes, yeah.
Actually, all the thyroid investigations were done when the patient was in ICU on day 3. Because usually we tell the thyroid investigations done in ICU are actually, it has to be repeated later.
No, so you need to
were
understand that,
repeated.
so if you understand that, if what will happen in sick euthyroid syndrome is that your TSH will come down, your T3, T4 will be low. If your TSH is 100, it's even
That is
more.
the thing, it was too much high.
So no, even if it's about 10, I will consider it to be significant. Low levels, you have to be concerned that it may be because of illness. High TSH, any high should be actually higher. So if it's more than 10, I would think of this. So definitely the only indications in which thyroid function should be done is like this, encephalopathy. Like if you have bradycardia, if you have hypothermia, if you have hyponatremia, those situations you should definitely do that. Now that's a big message. If the TSH is high, you don't ignore it. If TSH is low, you may or may not, depending upon the clinical picture.
Especially even during ICU.
Yes, even during, that is even more important.
More.
A high TSH will be even more important.
Thank you.
Thank you, Dr. Anusha, for this wonderful case. And now we will move forward to the next case, and continuing with the theme of diabetes. We will now be moving forward with the case of another very interesting case, which was found to have significant implications in terms of evaluation and management. And this is a case which Dr. Vibha will be presenting, which we manage in our unit and have been managing for a long time. So Dr. Vibha.
Good morning, everyone. So we have this 11-year-old boy who was born of non-consanguineous marriage, and he presented with growth failure. And he was referred to us for the further management of diabetes and celiac disease, as he was a diagnosed case of diabetes and celiac. So let's begin from the beginning. His mother, according to his mother, he was asymptomatic till 2.5 years of age. Then she noticed he was not gaining weight. He became lethargic and weak and lost his appetite, and he was passing urine multiple times. He had loose motions after the introduction of wheat products like Dalia, and his motions were sticky too. There was no history of any hyperpigmentation, salt craving, and no history of similar complaints even in the family. He had no history of any recurrent chest infections, but he had a significant past history. At the age of 1 year, he had orchidopexy done for the right undescended testis. And when he was being evaluated for his growth failure by his treating physician, what he had found that he has a cardiomegaly in his chest X-ray, and echo was done. And the echo confirmed that it was pericardial effusion. But all the investigation for the causes of pericardial effusion was done. Even all the investigations for the tuberculosis was done, but they came out to be normal. He born with a very good weight of 3.8 kg, and there was no perinatal complications. On the examination, what we found, he had no pallor, no clubbing, no lymphadenopathy, but he had single incisor, ptosis, and epicanthal folds. He even had high arched palate. His anthropometry measure shows he had a height of 122 centimeters, that is 1.25 standard deviation. And on genital examination, what we found, he has a prepubertal status. He already came with the investigations which showed he had a high HB1AC of 11, TTG level of greater than 200, but the GAD antibodies were not done due to some financial issues. So when he came to us, he was taking basal bolus regime, and he was doing pretty well. He was on 0.9 unit of per kg per day of insulin, and he was a gluten-free diet. He was able to maintain the HbA1c between 0.5.7 to 6 and TTG of 10 to 12. But what we have seen later on, that after the 9 years of diagnosis of diabetes, his TSH level tends to rise. It increases to 16, and he was TPO positive. The titers were high up to 500. So it is a known phenomenon that anybody has type 1 diabetes and celiac, he could also have hypothyroidism. So we started Thyronorm with a dose of 25 microgram. Okay, it was well accepted to us. Then 1 year later, what we found, he started to develop some irregular hyperpigmented patches, especially along the medial aspect of thigh. They were gradually increases in size and associated with mild itching. We treated this mild itching with giving cetirizine, and we think, let's see what happened. But somewhere in our mind, we were thinking like it could be adrenal insufficiency too, because hyperpigmentation is there. But we did the cortisol level. It came out to be normal. There was no electrolyte abnormality. And even there was no reduction in the insulin dose. There was no event of hypoglycemia as well. So it was not definitely a adrenal insufficiency. And what we have found, that he also developed some multiple scrotal masses, which was quite confusing for us, what it is really. Then again, we followed him closely. 2 years later, he did not have any pubertal spurt still at 16 years of age. He remained short. He was minus 2.75 standard deviation. And we could see in his pictures like he had immature facies at 16 years of age. And he had central incisor, as I mentioned in the examination. We did the workup and we found he had a high FSH and LH and low testosterone value. So definitely he has gone gonadal failure this time. We did the bone age examination and it was delayed by 2 years. So he has gone through, like in this 14 years of life period, he was hit by so many morbidities. And if I summarize all this, then it was at 3 years of age, he was diagnosed with type 1 diabetes and celiac disease, along with short stature. He also had pericardial effusion at 3 years. And then 11 years, he had hypothyroidism, which was TPO positive. At 12 years, he developed some irregular hyperpigmented patches. And at 15 years, he had gonadal failure and the short stature persist. So all these pictures with all these multi-system involvement, for me as a fellow, I could still think of only two possibilities as a differential diagnosis. He has a thyroid involvement, he has pancreas involvement, he has adrenal involvement, he has gonads involvement. So I would like to keep my differential as the first, autoimmune polyendocrineopathy syndrome 2, because thyroid, pancreas, and the adrenal is involved in the APS2. It could be also immune polyendocrineopathy, as discussed by Sir yesterday, but it could be another unknown genetic mutation, which is not in my knowledge yet. So we think as it is a immune polyendocrineopathy, so we referred him to as an immunologist. But what he did, he did some multiple investigations, and he also did ANA level, but it came out to be normal. So he sent the child back to us. So we were again thinking what still the diagnosis is. Somehow the parents were not able to manage for the genetic testing, but by convincing them anyhow, they finally were ready to get the genetic test done. And when the clinical exome sequencing report came out, it showed that he had a genetic mutation at SLC29A3, which was autosomal recessive, and it was homozygous. And this genetic mutation is responsible for histiocytosis lymphadenopathy plus syndrome. And coming to what does this SLC29A3 gene do, let me explain this first. Basically, it helps in the production of a protein known as equilibrium nucleoside transporter. It is found especially in lysosomes and mitochondria. And when there is a genetic mutation in SLC29A3, all the nucleoside will lead to accumulation in the lysosome and the mitochondria, and it will lead to decline in the cellular function. And if it happens in the mitochondria, then there will be shortage of nucleoside, and it will lead to the energy production impairment. We all know when the mitochondria is involved, it will lead to the multisystem involvement. So same happens in this case. So what histiocytosis lymphadenopathy syndrome is? It is basically characterized by the 4 histiocytosis disorders, and they are Fezalabad histiocytosis, this is one, sinus histiocytosis with massive lymphadenopathy, H syndrome, and pigmented hypertrichosis with insulin-dependent diabetes mellitus. And these are the clinical features which are present in these 4 syndromes. The slide looks too busy, so let me concentrate on the clinical features of our patient. He had epicanthal fold, he had hyperpigmentation, he had pericardial effusion, he had short stature, diabetes mellitus, hypogonadism, and the scrotal mass. So if we look the S syndrome, he is well fitting into the S syndrome criteria. But he had pericardial effusion, which is not present in the S syndrome. And the diabetes mellitus also, which is more common in PHID, that is the pigmented hypertrichosis, insulin-dependent diabetes. So cases have been found that has showed that the patients can present with the overlapping features of these 4 disorders. There is no genotype-phenotype correlation in these disorders, and these disorders are non-malignant. So let me show some case reports supporting this evidence. The same SLC29A3 mutation was found in 2 sisters. They had the mutation at the same site, but these 2 sisters present with different clinical manifestations. The one sister presented with sensorineural hearing loss and skeletal abnormalities, while the other one presented with short stature, flexion contractures. Now coming to our case, we had a mutation at C200A arginine guanine mutation at the SLC29A3 mutation. This gene was previously reported in a Faisalabad histiocytosis, and that patient presented with joint deformities, sensorineural hearing loss, and lymphadenopathy. But our patient did not have any joint deformities, lymphadenopathy, or swelling. So these reports clearly show that if the patient is having SLC29A3 mutation, this is not compulsory or this is not necessary. They will have same phenotype. They can present with variable clinical manifestation. So coming to the patient back, he is being given gluten-free diet. He is on basal bolus regime with 0.9 unit per kg per day. He is on Thyronorm of 62.5 microgram. And we have started the puberty induction 1 year back. Now he is on 100 milligram monthly injections, and he is doing pretty well. So the key points from this case is if there is any patient with non-autoimmune insulin diabetes, with atypical comorbidities like gonadal failure, hyperpigmented diabetes, always suspect there is something else and go for genetic diagnosis. Hyperpigmentation or the hypertrichosis is the hallmark of this syndrome, and there is no genotype-phenotype correlation in this syndrome. And management is as per as the comorbidities. Steroids, immunoglobulins, and tocilizumab have been used in these cases. So thank you.
Thanks, Vibha, for this wonderful presentation. So I think this has been a diagnostic dilemma, and he had actually come to me when I had just come back from Australia around 13 years ago. So this was, I think, 2009 or 10, I saw the case. He was very young, presented, admitted with DK. And since then, he kept on evolving. He had initially celiac and type 1 right at 2 years, which is too early for celiac to develop. Then he had developed those pigmentary lesion, then later on hypothyroidism, then this gonadal failure. So we said it's a IPEX-like syndrome. That's what I was thinking. This could be a possibility. That's why we were pushing for genetics, and then we found this unusual phenomena of H syndrome. So we'll have some comments from the chairpersons first.
Yes, so it means that we don't have to be judgmental just on the initial, because these are the syndromes and other things which are going to evolve over the years, and we should have keep our eyes and ear open. And now genetic is going to have a good role, supportive role. But one more thing that I wanted to add, that which genetic lab we are consulting, and whether this is there can be so many variations and changes. But whether they are relevant to that particular case or not, this is also very important.
Yes. So I think the most important thing is to look at whether they have, how they have classified, whether they have classified it as a pathogenic, in which it has been reported in a similar condition, or its variant of unknown significance. So in this case, clearly it was reported as pathogenic, and we have similar cases, although this is a very rare. I think if you look at this constellation, this will be one of the rarest presentations. Dr.
Sir,
Vikrant.
I have a couple of questions, sir. There was a single central incisor was present.
Yes.
So has it got to do something with the hypergonadotropic hypogonadism, or it was just an incidental finding?
So single central, we are thinking of MRI. We did for look for the
Lekin it was
central, which was
nothing.
normal. So hypergonadotropic hypogonadism aneurysm is the autoimmune phenomena, which I would say that he has
is-
got cutaneous, he has got autoimmunity in the pancreas, he's got autoimmunity in the gut. Same way his gonads have been damaged. And usually testicular failure is very, very rare as far as the manifestation. That is
Autoimmune.
because the testes are
Blood testis barrier.
they are
is
the
there.
barrier. So why do you think he got the testicular failure in this case?
Might be due to
He underwent orchidopexy. So we don't know whether there was some exposure to the testicular antigen and that could have resulted
There
in
could
the
be
damage.
secondary antibodies
That
after
could have been
Torzania,
developed.
some procedure.
Yes.
Sir, are you planning to start some immunosuppression or immunoglobulins
We
when you have the genetic
we have
diagnosis?
sent it to the immunologist. Let them
Immunologist,
decide
sir.
on that.
So when we have got the, so it is going to be a bit decisive for the patient.
Yes,
It will
definitely. So
ultimately
we
change the
sent to
outcome.
the, even at 2 years, we sent to the immunologist, but then
But he's
now
not,
again,
not doing anything. Sir. Okay.
So I think thanks a lot, Vibha, for this wonderful case. And now we'll move forward. We have talked cases related to diabetes insipidus, diabetes mellitus, very interesting case of Hashimoto encephalopathy, then this H syndrome. We'll now move forward towards a very interesting and intriguing case of early puberty. And I'll invite Dr. Nitya, who will be presenting this case. And this is a case which is, we have seen cases similar, rare, but this is a very interesting finding again. So early tumor is what she is labeled as. Okay, Dr. Nitya is working currently in Thrissur as assistant professor in Department of Pediatrics. And last time also she presented a wonderful case on PHP.
Thank you, sir. A very good morning to one and all. Let me thank Anurag sir for this opportunity. And I'll be presenting a child, Miss N, 13-month-old girl who had come with bleeding vagina for 2 days. So since the antenatal history is significant, we'll start with antenatal history. She was the first child of non-consanguineous parents. The pregnancy was uneventful and had regular antenatal checkups. Her mother had quickening at 6 months. Initial anomaly scan was normal till the mother was diagnosed to have hypertension and was started on nifedipine. 29 weeks ultrasound scan showed a hyperechoic round mass anterior to the brainstem in the suprasellar area, which was around 3.2 into 3 centimeters. In the subsequent scans, actually, the size was increasing. The 32-week scan showed around 3.6 into 3.3 into 3.7 centimeters, and the 34 weeks, which showed again increasing size of the mass. Then the pregnancy was continued, and she was born by vaginal delivery. She was induced at 36 weeks, 3 days for severe preeclampsia. Birth weight was 1.7 kg, and the baby cried soon after birth, and clinically baby was normal with neurological and other system examinations were normal. I think the face is not seen, so it's okay. Postnatally, there was respiratory distress. The baby was on O2 by hood for around 24 hours and was discharged from our SNCU on day 11 with a discharge weight of 1.6 kgs. An MRI brain was suggested considering the antenatal abnormal ultrasound. So the MRI brain showed a lesion, well-defined space-occupying lesion with lobulated margins. It's well seen in the screen, which was measuring around 4.1 to 3.9 to 3.6 centimeters. And axial view also showed a very big lesion, which was over the clivus with no bony erosions, but caused compression of the and the posterior displacement of basilar artery, pons, midbrain, and cerebellum. And superiorly, the lesion was pushing the optic chiasma, as you can see in this, and the floor of third ventricle, which is the lesion was bulging into the ventricles. Pituitary infundibulum was not seen separately, but no obvious hydrocephalus was seen. So considering this, DD of craniopharyngioma teratoma was given, and we had sought neurosurgery opinion. The child was referred to a bigger neurosurgery center in our state, but they didn't go, and baby was lost for follow-up. At 13 months, they came back, as I mentioned, with bloodstained vaginal discharge. No history of local trauma or increased frequency of maturation, no history of head trauma, cranial radiation, or other infections. The child was active and playful, had good interaction with parents. There was no history of abnormal posturing or any suggestive convulsions, no weakness of limbs or cranial nerve palsies, no history of recurrent vomiting or loss of consciousness. Developmental history, vision, hearing was normal. She was fully immunized for the age. No significant other family history we could get. And apparently dietetic history, parents told the baby was eating little more. It's taking more feeds compared to other children. Otherwise, no significant history. On appearance, she was active, alert, and playful, appeared little obese. Vitals were stable. Head size was normal, about except for the plagiocephaly, and anterior fontanelle was closed, no sutural separation, no facial dysmorphism, eyes were normal, no neurocutaneous markers, and spine was normal. So Tanner staging was around B3, A1, P2. Anthropometry, they had the initial weights with them, so we could plot on the chart, and the baby was actually gaining weight. The present weight was 10.1 kg, which was between 50th and 97th centile, as well as the length, and the head circumference was normal. Coming to system examination, nervous system examination was apparently normal, except for the brisk or exaggerated reflexes in the lower limbs, which was appreciated. Otherwise, nervous system examination was normal. The other systems were also apparently normal. Abdominal examination showed no any other palpable masses or hepatosplenomegaly. So at this point, our provisional diagnosis was a 13-month-old baby presenting with central precocious puberty with etiology, probably the antenatally detected intracranial tumor. Looking at the preliminary investigations were actually within normal limits, except for when the hormonal profile, we got high LH 5.38 with high estrogen 282.7, which again showed a gonadotropin dependent on a central precocious puberty. Prolactin was normal. Bone age was corresponding to around 24 months. An ultrasound breast was done. Clinically was like breast tissue only. Anyway, we confirmed with an ultrasound, which showed bilateral homogeneous fibroglandular breast tissue. And ultrasound abdomen and pelvis showed a uterus. It's actually with pubertal morphology. Uterine size was 4 into 2 into 2.4 centimeters, and endometrial thickness of 10 millimeters with bilateral ovarian cysts. So it was suggestive of pubertal uterus. So we went ahead with MRI brain, which showed again a fairly well-defined extracellular lesion in the supracellular area with a mild interval increase in the size. So now the tumor size has become 4.97 into 4.2 into 3.7 centimeters, which was suggestive of pedunculated large hypothalamic hamartoma. So this was the tumor scene. So now at this stage, our diagnosis is true isosexual central precocious puberty, secondary to the intracranial midline tumor, most likely hypothalamic hamartoma. The child was started on injection leuprolide. We usually start with monthly injection, so 3.75 mg monthly. And again, since considering the size of the tumor and this, so I mean early presentation, so we thought thought of sending them for early surgery. It's needed, but again, bystanders were not willing, so we just continued the treatment. Even they didn't even go for the consultation. So within a month, she presented with episodes of laughter. So as classically we all know, it's gelastic seizures. She again had one episode of GTCS as well. I hope all of you could appreciate that. So she had several such episodes of laughter, which parents initially took it as normal. When they brought the child to OPD and we witnessed once in OPD, then we came to know it's like, we thought if it's gelastic seizure, parents are completely like, it's a normal playing thing. And suddenly the abrupt ending, and then she will restart what he was doing before. So, and she presented with it's okay. And again, she had GTCS as well, which was controlled on sodium valproate and
JNR analogs. On regular follow-up, now she's 3 years old. She's taking monthly leuprolide and she's much better symptomatically. Seizures also controlled. Her weight and breast size is reduced. No further vaginal bleeding, and the gelastic seizures are well controlled. So as we all know, we have been discussing about hypothalamic hamartoma in the last couple of days. It's the most common organic cause of central precocious puberty. It's a developmental malformation with disordered neuronal migration. As her told, hamartoma is actually normal tissue in an abnormal place. And central precocious puberty is more likely to occur in large hamartomic lesions with attachment to tuber cinerarium. And there could be associated cognitive malfunctions and behavioral disorders. There are two types, sessile or intrahypothalamic hamartoma and pedunculated or parahypothalamic hamartoma. And the unregulated pulsatile release of GnRH, as we know, which will cause the early onset and the rapid progression of puberty. And the treatment is usually medical management by GnRH analogs and the control of seizures, and surgical management probably in refractory cases. So the key points in our case will be, this is actually, we all know that we should think of hypothalamic hamartoma when we see a child who's less than 3 years. That's how we're basically taught. Less than 3 years, precocious puberty, think of HH. But here is an antenatally detected tumor, which is not very common. And as I mentioned, the early age, it's a clue to hypothalamic hamartoma. Rare presentation of large ICSOL, large space occupying lesion without a neurological presentation. And actually the child presented, the initial presentation was endocrine. She didn't have any kind of neurological presentation in the early phase. And I just want to discuss regarding the surgical correction, whether it is feasible here or any other treatment options like laser or is being done. So that's all. Thank you.
Thanks, Dr. Nitya, for this wonderful presentation. And I think the major, finding couple of them, one, it was detected antenatally, and second was a very large tumor. So Dr. Subrato, what will you recommend for the size of the tumor?
What they say is if it's more than 1 centimeter, you need to go for surgery. But having said that, I saw a child about a year ago, a 3-year-old girl who had started menstruating from 2 years of age. And this child had a pedunculated hamartoma, which was about 1 centimeter, which is actually an indication for surgery. But the reality is no adult neurosurgeon will even venture anywhere close to these children. And since I'm from CMC Vellore, I was tempted to send there because there is a dedicated pediatric neurosurgeon, but they didn't go to Lanka. They stayed away in Ramraj. And right now is being followed in AIMS by one of my colleagues. I met him yesterday. Apparently, the precocious puberty is in good control. There are no neurologic signs and symptoms. There is no gelastic seizures. So it is a time bomb. But having said that, there is no optic compression. So that is why, but I think the rule of thumb is do have a neurosurgery consult early, because these children, okay, government hospital, etc. But if you don't do the right thing at the right time, then there is irreparable damage to the child. And the second issue, which I want to bring up, sometimes when you send these children to fly-by-night operators, neurosurgeons, roving neurosurgeons, who will take out anything they can, and including your purse, they'll pick that up as well. These children are not sent for radiotherapy. And that is another message, that a cranio management or a hamartoma possibly if you remove it completely, they don't need, but cranio certainly don't, take bits of it and then put them on the side and hope they'll do the best.
I think that's a very important point. So surgical management largely is more for neurological indications, not for endocrinological indications. So we have seen patients who just had isolated puberty, no neurological, managed very well with GnRH, and it doesn't increase. It's basically a migrational defect. So it's not going to cause increased size further, but yes, uncontrolled seizures, very large pedunculated lesions, these are the ones in which surgery may be indicated in that setting.
Actually, after the GnRH, starting GnRH therapy,
Yeah.
seizures are actually controlled on sodium valproate, I should say.
Yes, it will be
So-
because of valproate. Yeah.
Okay. So still, I think
We can hold
sir-
on. You can have an opinion. I think in this case, it is not going to progress in that sense. So if your seizures are refractory, then probably you may think of it. But otherwise, hold on. I think that's the message. Basically.
can it be any other lesions, sir, other than hypothalamic hamartoma?
The same, what I want to echo, Dr. Nitya, that first, that this is a case of central precocious puberty, and you have already told that this is an space occupying lesion. But still, because the caveat is that hypothalamic hamartoma, which is a migrational defect, usually don't be reported intimately, one. Second, with this size and without any other neurological abnormalities. So since we all know that on endocrine issue, we have to manage like this only. But still, I'm a bit skeptic that this is really hypothalamic hamartoma or something else. We have to have at least a close monitoring before taking it out. So this was.
I think that's a very important point. So I think we'll move forward with the
Thank you,
next case. So we have been discussing about very, very interesting presentations, rare presentations. We discussed about the H syndrome. We are discussing about the unusual presentation of the common manifestations. We'll now be talking about a sort of a rarish or a very intriguing in which there's a management challenge, which is there in that regards. And this is a case of ectopic Cushing syndrome. And I'll request Dr. Dhwani, who is working with us as a fellow in pediatric endocrinology, to discuss about this. Very, very, not very difficult in terms of evaluation, but more in terms of management and going toward the right side. Yes, Dr. Dhwani.
Thank you, sir. Good morning, everybody. So straight on moving to the case. We had Mr. N, a 23-year-old male wrestler who came to us with complaint of progressive weight gain for 2 to 3 years. This was him in 2019 and this was him in 2022 when he came to our OPD. He also had complaint of weakness, severe lower backache, and gave a history of itchy lesion all over the body for the last 2 to 3 years, for which he was on Ayurvedic medication. On examination, he was obese and had a BP of 153/115 millimeters of mercury. He had classical features of Cushing, round moon faces with facial plethora, humpback, central adiposity with thick violaceous stria. And if you focus on his arms, you can also appreciate the skin lesion that he had. So, and he also had features of proximal myopathy. So we were very convinced this would turn out to be an exogenous Cushing, and we went ahead with the workup. Our initial workup showed a very high 8 AM cortisol with borderline hypokalemia. We went ahead with an overnight dexamethasone suppression test, which again showed a very high cortisol level. His midnight salivary cortisol was also high. To confirm the diagnosis of Cushing, a low-dose dexamethasone suppression test was done, which was again not suppressed. So we had confirmed the diagnosis of Cushing. Now, having confirmed the diagnosis, we need to know if it is an ACTH dependent or an ACTH independent Cushing. So the ACTH level was done, which is again very high. The cutoff to define Cushing syndrome as an ACTH dependent lesion is ACTH levels more than 10 picograms per ml. So you can see this was a significantly higher ACTH level. Now, having made the diagnosis of ACTH dependent, it was important to understand if it was a pituitary ACTH secretion or an ectopic ACTH secretion. We went ahead with an MRI of hypothalamo-pituitary region, which showed no adenoma. A high-dose dexamethasone suppression test was done, which was again not suppressed. Cortisol levels were seen, very high cortisol. So a diagnosis of ectopic Cushing was considered, and we went ahead to screen for the focus of this ACTH production. Contrast-enhanced CT of the chest and abdomen were normal. We went ahead with Dotanok PET, which is an excellent modality to screen for neuroendocrine tumors, which was again normal. So the source of ectopic ACTH reduction remained a mystery to us. We all know that ectopic Cushing is a rare cause of Cushing syndrome, accounting for only 5 to 10% of all cases of Cushing syndrome and 10 to 20% of ACTH dependent cases. The most common cause of ectopic Cushing are the neuroendocrine tumors, with bronchial carcinoids being most common in the pediatric age group. It is associated with significant morbidity due to the underlying pathology, as well as hypocortisolism associated negative impact on the cardiovascular and bone health. In patients with non-malignant cause of ectopic syndrome, the standard mortality ratio is between 2 to 4, with cardiovascular deaths being most common. So it is extremely important for us to evaluate for the cause, and if we can identify the focus, remove it as soon as we can. Not only will it help with improving the symptoms of Cushing in this patient, but also allow prevent progression of other comorbidities that the patient may have. So looking at the Endocrine Society guidelines, once you've established Cushing syndrome biochemically, you treat comorbidities. If it is an ACTH independent lesion, go for adrenal imaging, and then for unilateral or bilateral adrenalectomy as per the scenario. In those with ACTH dependent Cushing, if you have a pituitary lesion, resect the lesion if you can. In those with ectopic, again, if you have an identified lesion, tumor, go for resection. When you cannot resect a lesion, or when the patient is surgically unfit, or if you cannot find the focus in an ectopic Cushing syndrome, it is important to start a steroidogenesis inhibitor right away. One can go for glucocorticoid receptor antagonist when you have impaired glucose tolerance in these patients, and bilateral adrenalectomy remains the last resort in the cases. So ketoconazole therapy is the steroidogenesis inhibitor commonly used in Cushing syndrome. Apart from being a steroidogenesis inhibitor, in vitro and in vivo studies have established that it also has an ACTH suppressive effect. It is started in the dose of 400 to 1200 milligrams in 2 to 3 divided doses because of its short half-life. An average remission rate of 64.3% was found with ketoconazole therapy, ranging from 45 to 93% remission. And the common adverse effects one can see, one needs to be wary of when starting on ketoconazole therapy are hepatotoxicity, which is seen in 14.5% cases. It usually develops within the first 4 weeks of starting therapy. It is usually asymptomatic and reversible. There may be subtle GI symptoms and hypogonadism, which is more common in the male hypogonadism that one may encounter. And as it is an enzyme inhibitor, one needs to be cautious about drug interactions that it may have. As per the management of this patient, we had started him on ketoconazole 200 mg thrice. We started off with twice daily, and we had made it thrice daily based on the clinical improvement. He was symptomatically better on 200 mg thrice daily. On treatment, his ATM cortisol was again still high, but had come down from his higher level of 900s. He was started on amlodipine 5 mg, at which his BP has come down to 140/80. And we had closely monitored him for his LFT, which had remained normal on ketoconazole therapy. We planned further workup for the cause of Cushing because we cannot really continue ketoconazole therapy for. Yeah.
So I think this is one which is more of a management challenge as to how do we localize ectopic Cushing. And this is quite a scenario where we go on a fix. We have already done many workup. It's not picked up. Even in adults, 50% cases, you will be able to pick up. Children, carcinoids may be very small. So we have referred them to AIIMS also to see if they can offer something new, some special type of functional imaging, whether they can do in. So he's being worked up there. And hopefully we'll get something out. But ketoconazole has at least salvaged him. He had become really, really Cushingoid. And from there, things have gone from that perspective. Yes, Dr. Sabir.
One very quick comment. Are we not doing this inferior petrosal venous sinus sampling?
Okay, so we are not doing it routinely here, that's number one. So that is one of the reasons we have sent him. But if you really look at it, you cannot have such a small tumor in the pituitary to produce such amount of cortisol, which is not suppressed by a high dose dexamethasone suppression test. So theoretically, if you go by the protocol, IPSS will come up at the list. But somebody whose cortisol is 900s, ACTH is 160, 170.
See, that's what the other, the cases that I've seen where it is, where it is actually Cushing's syndrome.
Yeah.
Where it is Cushing's disease.
Yeah.
The ACTH may be 800, 900,
Mm-hmm.
So this 160 is also a little bit troubling me because it's raised for sure, but to cause this high level of cortisol production, but having said that, that has no bearing on the management because the management has to go on regardless of the cause. And I think, in this chicken or egg first, I think here is the chicken first. The egg we'll find out later. But having said this is very interesting. And, as they say, Kolar Goldfield, part 1, the part 2 we'll be waiting for.
Definitely. So we'll work up. We've sent for IPSS, but I doubt that there will be a lesion there because such high levels with a very small lesion, which is not even picked on MRI, and all the microadenomas always suppressed with high dose DEXA. His high dose DEXA was 600, which is like unbelievably high. So Dr. Hemchand, any experience? Okay. Any comments from the chairperson?
Sir, was the patient having hypokalemic metabolic alkalosis in this case?
No. So actually in adults, usually when you have a very rapid course, so that's more from the adults that 800 to 1000 figures often comes up. They present more with hypokalemic alkalosis pigmentation. They do not develop Cushing-White features because it's so rapid. So it's like a lung carcinoma or something. They will die in a year or so. This means this has been there for a couple of years. I think the history also shows. So this is not a malignant lesion. If at all, has to be a benign lesion.
Sir, has he lost weight on this ketoconazole therapy?
On ketoconazole, he's looking much better actually. So he actually came in the on-site session also, and his Cushing-White features have come down dramatically. So he has responded, but how long will we give a medication which is potentially toxic? So that's why we said, okay, let's get an opinion and see what else can be found out on that case. Thanks,
Thank you so
Dr.
much.
Sunny. So I think this was another interesting case, and now we will have two very, very interesting cases coming in from Dr. Subrato. Dr. Subrato needs no introduction, and he is the prominent pediatric endocrinologist of the country. And he has a plethora of immense amount of cases which are there, and also a lot of insight, which provides new practical information to us. So we always request him to have a couple of cases which will be there with regards to the case conundrum. So if you're taking the questions at the end of the session, there will be a question from the wider audience in the whole session.
Sure. So I think, Dr. Anurag, as usual, has done a marvelous job of keeping us to time. And I'll also time it to perfection so that we should finish by the stipulated time. With the kind permission of the chair, I'll start. Dr. Anurag and I go back 10 years. And what is very interesting, as I will go along, that we have exchanged cases from time to time. And the most important message that these cases, or whenever somebody says, I learned from the book, I said, that's wrong. You learn from the patient. Because the patient will teach, has not read the book. So you may have read the book, the patient has not. And so each time when we think we know it all, there'll be another case which will make you feel that there's so much more to learn. So anyways, in continuum with yesterday's glucose, metabolism and the intricate role of genetics, that is again illustrated by the first case. So I've timed it, I've called it exotic hypoglycemia. I think all the glucose metabolic disorders with monogenic diabetes are exotic disorders, mainly because we didn't know about them 10 years ago. So this was a 1 year, 8-month-old girl child who presented with high blood sugars, had actually presented in Bihar with DK, then was on insulin. But the family history, and ultimately it's all history, was born of a consanguineous marriage, 3 siblings, 2 doing fine, 1 with similar complaints had expired. And developmental milestones were attained timely. Growth, as you see, was pretty okay. And clinically, the baby looked, the toddler looked pale, but there was no syndromic phases. Otherwise, things were normal. So it come with diabetes. So blood sugar 439, A1C 12.2, C-peptide 0.7. Now, sometimes when we read from textbooks, we read from, abstracts, we sometimes don't focus because there's so much information on some minutiae. And that is why this case I thought I should talk about to actually kind of enunciate the minutiae. The C-peptide was low and the urine glucose was triple plus. So the child was on subcut insulin therapy and a diabetic diet. Now, this is what we found on routine exam. Was anemic, but macrocytic with MCV of 101 and MCHC 27.6. And so peripheral smear, anisocytosis, macrocytes, and normocytes. So we work up for macrocytic anemia. Vitamin B12 was normal, folate normal, and ferritin also was normal. So why this macrocytic anemia? So now, let me stop for a moment. Sometimes when we do these presentations, to be candid with you, we want them to look extra good. It's like, wow, we thought of it and we got it. So there was this sense that, what is this macrocytic anemia doing there? But I'll be very, very candid. What really made me think out of the box is this baby looking so cute, sitting in the mother's lap, looking so innocent with sugars of 400 and receiving high dose insulin. I said, there has to be something more to it. And so I asked for a MODI gene panel from MedGenome, which, coming back to one of the chairpersons saying that you have to choose the right lab because there are so many that today, if you throw a stone, likely you will hit an Apollo Diagnostics or you will hit one of these genetics labs. So the interesting part in this is that this boy immediately arranged, our executive for the blood test, and we got the results 3 weeks back. And what did it show? It showed an SLC19A2 gene homozygous on chromosome 1. And this is consistent with the diagnosis of thiamine-responsive megaloblastic anemia, aka Rogers syndrome. Now, the definitive treatment is thiamine, which is, as you know, B1. And they also have actually hearing difficulty, but this child had none, and there's no optic atrophy. So the response to treatment, insulin requirement decreased, blood sugars normalized, and eventually subcutaneous insulin therapy was stopped, anemia resolved. And these were the follow-up investigations, where the hemoglobin had risen, the macrocytosis had disappeared, and the A1C had become completely normal. Now, the important thing to reiterate out here, that MedGenome at that point was doing SLC, just SLC19A2 gene in the MODI gene panel. And be aware that this is no longer in the MODI gene panel. And so this was actually a fortuitous diagnosis, but look how we changed the child's life. Insulin off on just half a tablet of thiamine, which costs less than 50 rupees a month. And now the second child was a cousin of this child, came a year and a half ago. And I said, same thing, high blood sugars, A1C high, C-peptide low, and there was macrocytosis. And guess what? Here I told the fellow, don't do any other gene. Do SLC whatever, A19A2, I can never remember it. So oral thiamine was started along with insulin. And guess what? Everything normalized and actually unmasked an iron deficiency anemia. And the peripheral smear showed microcytic hypochromic. And look at the C-peptide, it improved. Even the other child also, the C-peptide improved. So what's really happened? It's an autosomal recessive disorder, megaloblastic anemia, diabetes mellitus, sensorineural hearing loss. But in the index case, there was no sensorineural hearing loss, But in her cousin, unfortunately, there was hearing loss. And the treatment is thiamine. The RD of thiamine is 1.5 milligram per day, but here it will give a higher dose. So SLC19A2 gene codes for high affinity thiamine transporter THTR1, which is involved in intracellular transport of thiamine. Reduced intracellular thiamine causes defective RNA ribosynthesis and megaloblastic changes. So with megaloblastic anemia and normal vitamin B12 folate levels, with or without diabetes or hearing loss, and there is response to oral thiamine, is a clinical response or identification of a homozygous pathogenic variant in SLC19A2 by molecular genetic testing. So lifelong therapy with thiamine is required. Complications secondary to poor glycemic control have to be looked for, but in this case, the glycemic control has been excellent. They need yearly surveillance, especially hearing, hemogram, and also the glucose intolerance. It's a rare type of disease caused by mutation to single gene, and which are different from type 1 or type 2, which are polygenic. And genetic testing can give accurate diagnosis, can modify outcome by refining management. Two main clinical phenotypes are neonatal diabetes and maturity onset diabetes of the young. Now, these are the litany of monogenic diabetes. Yesterday, a lot of them were covered. And I think truly the hallmark of today's meeting, in this year's meeting, has been to expose the role of genetics in the diagnosis of esoteric disorders. So when to do genetic testing in diabetes? All children with diabetes onset before 6 months of age, negative pancreatic autoantibodies, and diabetes accompanied by other non-pancreatic features suggestive of a syndrome. One may ask, why didn't I do the GAD? It was just a sixth sense, a clinical sense that this baby does not look like a garden variety type 1. I went for the gene study, and guess what? Even the cousin turned out to be Rogers syndrome. So it's important for us to remember we have a powerful tool, and it can bail us out sometimes, and it can also confirm a clinical suspicion. So thank you for a patient listening. The one on the left is Ariba, the older one, and the other one is Adiba. Unfortunately, she's complete sensorineural deafness, and she hasn't developed speech. And certainly, hearing aid is a must now, may require cochlear transplants in the future. Thank you.
Thanks a lot, Subrata, again for a wonderful case. We discussed often that we have this potassium ATP channel defect in which you will have response to sulfonylurea. We now have another drug which really wonders on that regard. So I think this was a very, very interesting. So just what Dr. Subrata said, you have 4S, which we always say when you think of a genetic cause. If it is very soon, so less than 6 months, very severe, syndromic, or segregating. So this case was severe, soon, syndromic, and segregating, which really put when you should do a genetic testing in that regards. Any comments from the chairpersons?
Sir, actually, I want to share my experience regarding thiamine responsive megaloblastic anemia. Currently, I have a girl, but he was not totally asymptomatic on thiamine. So I had to put her on glipizide, and she's doing well on that. So, sir, what is your experience, sir? Will it be needed for long, or it is going to relent on its own?
My answer is, I don't know. The reality is, it is not, KTP channel defect. So while adding glipizide may make us feel better, but I don't know, because the literature, what it says is if you have diagnosed it late and already some changes have happened.
Beta cell might have already got damaged, exhausted. So all those things, you may need insulin also.
So you may need
glipizide
insulin.
may not work for a long time because you will all exhaust cells. So if at all you want something, it will be like DPP4 inhibitor, which are good for the beta cells. But ultimately insulin will be required in that late onset cases.
And also remember that these sulfonylureas, I learned this long time ago when I was, say, maybe even a PG in JIPMA, somebody came and gave a talk on diabetes, and they say the sulfonylureas are a key to the cupboard. That means it will extract insulin from your system if there's insulin in the cupboard. If there's no insulin, then your sulfonylureas are not going to work.
And they will make your cupboard empty also.
Empty
So very
also,
quickly you will
that-
go into the failure also.
And
So if you
that-
establish-
And that is very pertinent, as Dr. Anurag with his very, very explosive but informative talk on type 2 diabetes. Avoid sulfonylureas in adolescent diabetes. Don't treat them fine, but don't give them like the GPs do, sulfonylureas.
Downhill.
Downhill. Or
Glimepiride. Oh, yeah, whatever.
glycoside.
So now we'll move forward quickly to the last case of this session, which Dr. Subrato is again talking a very interesting case of DSD. So over to you, Dr.
Thank you. Thank you, Anurag. Anurag and I are known better as Bade Miyan, Chote Miyan. We have been doing this act for the almost last more than a decade. But I want to start this case by saying that समय से पहले या तकदीर से ज्यादा ना किसी को कुछ मिला है ना मिलेगा. ये समय से पहले था. I had prepared this DSD case about 5 years ago. I came late, and I still remember Hemchand was giving a talk on bone age, and there was supposed to be this case on DSD right after. But I had just come in from my Lucknow, Kanpur trip, and I said कि ये तो थोड़ा postpone करना पड़ेगा, but the program was tight. So whatever, but that gave me an opportunity to produce Bahubali Part 2. So let's go on with this. So this is a 2-year-old, 2-year, 8-month-old child, Jessica. She looks like a little girl, doesn't she? So cute. Symmetric external genitalia, no palpable gonads. There was a genital tubercle hypertrophy, meaning a clitoromegaly, and pelvic ultrasound showed a uterus. What is the diagnosis you will think of if you see this constellation? What is the diagnosis? This is a garden variety CAH or enlarged clitoris, no palpable gonads. So it could be a, simple virilizing if there's no history of vomiting and salt losing in infancy. Could be. In fact, that was the diagnostic label with which this child came. Query CH. Why? They saw the uterus and they saw the clitoris. And guess what? I repeated the USG and I found there was a uterus. So what are the diagnoses you should do if you're suspecting a CAH? So 17-hydroxyprogesterone, DHEAS, I routinely do a testosterone. And in this case, or a lot of cases nowadays, I do a karyotype. In those days, I was visionary. I did the karyotype. And we did the repeat pelvic ultrasound. So surprise, surprise, 17-hydroxyprogesterone was normal, DHEAS was normal, and testosterone was elevated. Can this happen? Well, it can, but little, rare. And repeat USG also showed a uterus. So then the karyotype report came and the shoe fell. And guess what it showed? The fish also showed that, XY. So now we have, and this is a genitogram which showed there are 2 separate openings, uterine structure not communicating with the bladder. So something else is going on. So this is an under-virilized XY male with impalpable gonads and uterus. Diagnosis? Anybody? Something going on here, right? XY, under-virilized male, impalpable gonads, and a uterus. So let's look at this. If you have 46XY present, gonads not palpable, then you think of pure gonadal dysgenesis or over-testicular DSD. And now, as you know, this is the nomenclature you should follow. It's not recent. It's been there from 2007-8, but now no longer such terms as male, female, pseudo-hermaphrodite are at all acceptable, especially in this today's, LGBTQ1, awareness scenario. Please don't use these terms. Otherwise, you'll have the wrath of the community and all the activists behind them. And if Ahila is here, she'll tell you that in Chennai now, these activists have made a certain demand that any case, and I'll come to that as soon as I finish this. So the terms have changed, just remember that. So in this child, at that point, we did a clitoroplasty, and we had a very good pediatric surgeon who did a laparoscopic exploration. We are talking about, I saw this child in 2021. So it was 10 years before. So it was 2011. So he found there was testicular tissue in a right overtestis, ovarian tissue in left dysgenetic gonad, and the diagnosis was overtesticular DSD. So this was a true hermaphrodite, and please don't use the term. And the plan was testicular gonadectomy, rearest female. And then the patient disappeared and gave us a chance to give an update on this child. And this is how the child looked. Dressed as a male. And on physical exam, external genitalia female with some labial additions. And the gender identity was male. Testosterone were 200 nanogram per deciliter, meaning there is some active testicular tissue somewhere. And the LH was high, FSH high, if your gonads are not responding appropriately. And the pelvis showed, an MR pelvis showed a uterus, a vaginal canal was visualized, and no gonadal structure were noted. But we are not happy with imaging in these sort of cases because these are very, very small pieces of tissue. The plan was laparoscopic evaluation and gonadectomy and start ERT after 3 months. That was a very simple plan, but that was 21. Again, lost to follow-up for 2 more years. And then I get a call in the last week of May, and I get a call at 8 a.m. from the pediatric surgeon. And how many of you are Bengalis out here? Anybody? Yeah. But Bengalis from Bengal. All right. So Alapon will know that people in Bengal, when they are formal, they'll say, hello, how are you? Bhalo acho, all that. But if they're in stress, hey, Subrato! Hey, Subrato! Oh, tor patient amar table pode ache. He's lying on the table. I said, who? Oy je patient ta party chile. What's oy je? Oy je ki ada sex fax bypar ache. Mane DSD, huh? So what am ki kete dobo? Mane this is his clinical history of a surgeon who's on the OT. He's really stressed that when he has done the laparoscope, he saw an anda out there. In 2 years, that thing had grown. And so what were the dimensions? 1.6 multiplied by 1.5 into 0.8. Since I knew this case, and that is the other reason I'm presenting this case, is how we try to do the best for the patient. They disappear, then they choose their time, and then guess what? He removed, I said, Ki keda dabo? And then means take it out. And guess what? It was a gonadoblastoma. And that was all he saw. He saw that, and if you read the fine print, it's all Leydig cells, Sertoli cells. These were actually producing the testosterone. And now by removing that, hopefully we will be able to go to our earlier plan. Now, this is for the house. What is the sex of rearing? This is a child who did not have prenatal sex, prenatal, androgenic effect on the brain. The baby looked so cute as a girl, but we allowed water to go under the bridge. And there was this overtestis producing testosterone. 200 nanogram per deciliter is actually, a mid-puberty level. And then what happens? This child goes out of control and say, I want to be a boy. Now, my hope is after removing this testicular producing, testosterone producing, mass, which is benign, hopefully, after starting some, estrogens, 3 to 6 months down the line, she may start behaving like a female, but the child hasn't come back for the Premarin therapy. And that is my biggest dilemma. I would like your opinion on this.
I
And
think that's a very, very important issue, because there are some times when which the brain may be programmed with regards to the sexual orientation, development and everything. One, of course, is the antenatal period, which is the most important. If you are antenatally exposed to androgens, you will have a much more masculine tendency. But this also, another plastic period is during puberty. So around this time, if your hormone levels are high, you may see a change in orientation, as we see in 5-alpha reductase. So now with so many changes being done, with all the surgery being done, it will be very, very difficult to even consider rearing as male, I believe. But she will have a cute...
phenotypically is a female, and you cannot reconstruct a male with that amount of facility. So we have actually, now we're dealing with a transgender who's actually a female.
So this is going to be a very difficult scenario. So maybe we'll have input, Dr. Vijay.
Yes, at the outset, what we can say that again, there are so many community and the whistleblower are there and so-called say activists. We, as a practitioner or as an specialist, we have to sit together with the family again, and we have to respect their with pros and cons, that these are the things, these are the feasible issue. But in this case, it will always be better to rear as female. But I think from that family side, still what I believe that they will still tend to say that कुछ भी करो इसको मेल करके पालो.
नहीं, it is the other way around.
Okay.
कुछ भी करो इसको female बना के रखो.
That is
और बच्चा बोल रहा है कि मेरे को male बनना है.
Yeah.
That is the major,
yes.
You know, that is, and guess what now the statute says? If ever in doubt, consult the patient.
Yes.
No mutilating surgery before the patient is old enough to give consent.
Definitely.
So that is why I wanted your house's opinion, because I am dreading the time when they all come back with all these reports, because I'm going to still ply with my original plan, which is ERT, and hope she settles down.
Right? Dr. Aila.
Okay, coming from a state where genetic...
you can come up here.
Yeah. Coming from a state where DSTs cannot be operated on without the consent of the patient till they grow to age. So now we are actually postponing puberty by using GnRH analog until the child can take a decision on its own. So we actually counsel the patients to let the child be as they are. Even if you're parents, you're not the owner of the conscience of the child. It is the child's ultimate decision on what they want to be. Because I learned this lesson from one of my patients. I get goosebumps. He was 21. He had 5-alpha reductase. DHT gel was not available. During a sports meet, he was discovered to have testis. He converted himself into a male, and he told me his phallus was so small, like 1 centimeter. He said, even if I don't have sex in the exactly defined sense of the way, I'm still a male. So my external genitalia does not make me into a male or a female. And you all should remember, these patients are going to come and haunt you. The parents will not be there to support you when we face them.
I think the brain is the most important organ as far as the overall sexual orientation, everything. So often we say phallic size 1.8 centimeters. These are all criteria which were based upon some person decided those criteria.
No, it was decided by John Money in Johns Hopkins, who said, this can't stand. Take it out.
He ultimately committed suicide. No?
Yeah, because as you know, Charles Raymer committed suicide and Money followed soon after.
So it's a paternalistic attitude which was there. So now we have to be much more open. And now with all these, as you said, the LGBTQ and RS or whatever, it is going to be very, very difficult to really have that. So we have to be very careful in this.
That's one. And I think, you know, just talking about it, I think a psychologist will have a huge role, like in transgenders.
No, in Tamil Nadu, the government, you approve surgery, which a whole team, which has to have a psychologist or a psychiatrist who's trained in looking after patients with DST, an endocrinologist, a pediatrician, a pediatric surgeon.
True multidisciplinary
and
team.
A social activist has to be on the team, and they have to approve surgery before surgery can be done.
Thanks, Dr. Ahila. Thanks a lot, Dr. Subrato.
Thank you.
I'll request Dr. Dhwani to come up and please felicitate Dr. Subrato. And Dr. Subrato's sessions are always enlightening. They are providing us so much knowledge. Thanks a lot, Dr. Subrato. Thanks a lot, Dr. Vijay and Dr. Vikrant for chairing these sessions. And now we'll be moving towards the next very, very important session, which is about the state of the art. You can give the schedule to me. The next important session is about the overview of novel therapy. And for this, I'd like to invite Dr. Yashwant Rao. Dr. Yashwant Rao is the head of Department of Pediatrics at GSVM Medical College. Dr. Yashwant, kindly come up to chair the session. And Dr. Sugandha Singh, who is working in Moradabad as a pediatric endocrinologist. So I'll request both of them to come up. And this session is basically about the overview of different disorders in related to pediatric endocrinology. So we are focusing on growth largely and adolescent gynecology as well. So Dr. Yashwant and Dr. Sugandha, welcome to the session. The CVs also there. So Dr. Yashwant and Dr. Vijay, kindly we can start off with the growth aspect we are starting. So your opinion maybe while we load the presentation. And I have to also take the few questions which are there. So just before that, I think we just missed on a few questions which are there. So this was a question about the thyroid one, which said that we see this pattern of TFT with no neurodeficits routinely. What are the prevalence of the same in pediatrics? So usually with hypothyroidism of that level, this is from Dr. Anusha's case, you don't see those neurological features. This is a very distinct autoimmune entity in which autoimmunity is causing the neurological features. Dr. Ragini is asking what were the scrotal masses which were seen. This was in our case, this was mostly like a local inflammatory lesion, which is what we are thinking of. Dr. Vijay Kumar is asking after surgical correction of tumor, what will happen to the endocrine pattern? So generally the endocrine pattern will not change because you will continue to have precocious puberty and hypothalamic hematoma in that regards. So I think we'll now move forward with this session. Dr. Vijay, Dr. Hemchand, kindly come up and start the talk. And this is about the long-acting growth hormone. And we have always had this problem from all the family members. They want to stop injections, avoid injections, and how we can make it easier in not having regular amount of repeated doses of injections. So I think Dr. Hemchand will shed a light on this.
Thank you, sir. I think this is a very, I think we are running behind time. I'm just on my timer also. So we are running behind time. So long-acting growth hormone, I think, is a very important topic because it's going to be very relevant for us in the next few months. I would say all of us are going to have access to it, and we should be well informed before we guide our patients on that. So I have put for myself these 7 questions which I thought we should look into more carefully. Are there any guidelines available for us as of today that endorse the use of routine long-acting growth hormone in children? What is good and bad adherence? What are the preparations available across the globe and are likely to be available in our country? Will the use of long-acting growth hormone improve growth velocity? What is it going to be its impact on IGF-1? Is there any evidence for use of long-acting growth hormone in non-growth hormone deficiency conditions? And some FAQs based on available literature. So let us jump into the well right away. Number 1, are there any guidelines that endorse the use of routine long-acting growth hormone? I think I have put across the common available guidelines which we tend to use when we manage our patients with children who have growth hormone deficiency. And unfortunately, there is no clear answer. Maybe the advent of the long-acting growth hormones have been very explosive in the past 3 years, I would say. Probably these guidelines were available at a time when this sort of a data was not available. But the answer to this question is no. At this point of time, they are silent about the use of long-acting growth hormone. They do not endorse it. At the same time, they do not stop us from doing it as well. What is good? I think this is the most important question which brought about the development of long-acting growth hormone. What is good adherence? A child who is on growth hormone, missing less than 1 dose of growth hormone per week is said to be good adherence. There's a reference for this. So I think children who have issues pertaining to adherence become the first criteria who become eligible for long-acting growth hormone therapy. So what are the preparations available? I think there has been explosive research looking into various forms of technology that are kind of helping in prolonging the duration of action of growth hormone. If you look at literature, there are much more molecules in this. I have put across 6 molecules, 5 molecules, I would say, which are currently kind of, you can have an access to it from some part of the globe. So these are the various, the market names and the technology behind this and the country where it is available. So if you see, you have this this depot preparation, then the Jintrolong preparation, which is probably marketed in China, then the Transcon, then the Somapaciton and Somatrogon. So I think the technologies are different, the doses are different, the principles of action are different, but I think the results are largely similar across these molecules. Okay, the crucial question: is there going to be an improvement in growth velocity? Is there going to be a significant impact on insulin-like growth factor? I think this is the most important question as a practitioner we face. Suppose I shift a child or I start a child on long-acting growth hormone instead of daily growth hormone, or if I shift a child from daily growth hormone to a long-acting growth hormone preparation, am I going to have the same oxylogical benefit? Am I going to push the child more into adverse reactions? So this, I think, was answered by a meta-analysis which included 11 studies from nearly 1,200 children, and 737 children were using long-acting growth hormone and 495 were using daily growth hormone. And what is it they significantly, they collected all the data, and what is, I think we should read the statement very carefully. Long-acting growth hormone therapy, no significant difference in terms of height velocity, no significant difference in terms of height for age standard deviation Z scores for bone age, insulin-like growth factor level SD scores, and incidence of adverse reactions. I think this is a very important conclusion this meta-analysis has done. And it has depicted it very beautifully in a pictorial format. If you see, this is the beautiful forest plot, and they have put across all the available studies, and they have kind of computed the mean average difference of height velocity Z scores. They have compared the height velocity Z scores in children who have taken daily growth hormone and the height velocity Z score in children who have taken weekly growth hormone, and they have not found a significant difference. So I am very happy. Suppose I attain the same height velocity Z score by taking 1 injection per week versus taking 7 injections on 7 different times of the day. I am happy. My parents are happy. The child is happy. So what is it that prevents us from taking it forward? The important look is to look into the IGF-1 Z scores as well. I think comparison, this is a comparison of the IGF-1 Z scores, erroneously mentioned as height velocity. And you can see there is a slight shift in the right of IGF-1 Z score, but not clinically significant enough. I repeat again, there is a slight shift in the IGF-1 Z score, but not clinically significant enough to really scare us from routinely propagating weekly once growth hormone. So now, having reviewed this meta-analysis, let us go to specific relevance for our practice, for our country. If you see our country, there are 3 molecules that have been studied by different researchers in different parts of our country. This is the preparation that was used, which was initially marketed by the LG, and later it was taken over by the Cipla, and currently it is not available. They looked into this data of 178 pre-pubertal children. 91 of them were on weekly once. They included both idiopathic and organic growth hormone deficiency. The long-acting growth hormone was given in a dose of 0.5 milligram per kg subcutaneously weekly once, and IGF was measured after day 4. What is it they found? They found there was a very good improvement in growth velocity in both the weekly ones as well as the daily growth hormone. The increment in height translating to an increment in height Z-score was very good in children who received this weekly once growth hormone therapy. So what does it say? It says that you are going to have a good increase in height if you use the long-acting growth hormone. This is the most important thing, which looked into the pattern of IGF-1 Z scores. I think that is what, as practitioners, we are worried about, the huge rise in IGF and the steep fall in IGF, which is seen with weekly once growth hormone, which is totally unphysiological. It's the daily growth hormone. It does not fully replicate the physiological growth hormone replacement. The weekly growth hormone definitely does not replace the daily growth hormone replacement that is done. The pattern of rise in the GH, the pattern of rise in the IGF-1. So what does it show? It shows that the mean IGF-1 was lower in the children who received before treatment. But if you see the increment, that the pattern of increment of IGF-1 Z scores was comparable and consistent in both the treatment groups. Although you do see a mild, the curve of the children who are on weekly growth hormone is definitely higher slightly, but it is comparable and consistent. This is with the first molecule they observe. But what is really a negative perspective about this molecule is the administration side effects was very significant in terms of the local swelling, the local pain, the local erythema, the discoloration, etc. was very significant. I think that is one thing which defeats the purpose of development of a long-acting growth hormone. Why do you want to give long-acting growth hormone? Not to improve the height, but for them to adhere better. Who will take a very painful injection once a week rather than going for a relatively pain-free injection 7 days in a day? I think many of them may opt for the second one. So, and it fell out of flavor. Okay. Then comes the second molecule. This is a molecule called as somapacitan. And it has used a very specific technology where they've used a non-covalent albumin-binding moiety that increases the half-life of the growth hormone molecule. And this is a study which looked into its utility on 200 children who received somapacitan versus daily growth hormone. And if you read that study, it has a good Indian representation from 3 centers as well. But remember, all of them were GH naive individuals. None of them were on post-intracranial tumor group of children were not there. And the youngest age is 2.5 years up to 10 years prepubertal children. This is a group of children which has been extensively studied. And they looked into the dose, which was established by a phase 2 trial, and 0.16 mg per kg per week was administered subcutaneously. So what is it they observed? They observed that the mean height velocity after 52 weeks was good enough compared to daily growth hormone. So as seen in the previous molecule, this molecule also, the purpose of treatment of receiving daily growth hormone versus a weekly growth hormone in terms of improvement in the growth velocity, there was not non-inferiority was established. It meant to say that weekly growth hormone is as good as daily growth hormone in improving the growth velocity. And this study also looked into the, as a practitioner, what is the ideal time to measure IGF-1 was also looked into in this very beautiful study. They measured IGF-1 at serial points of time after the injection. And what is it they found? They found, you see that they found that IGF has a peak after the injection, then it comes down slowly. And the peak, very few children cross the +2 SPS. So I think they have established the ideal timing of peak and ideal timing of taking the sample after the growth hormone injection. You can see the graph there, which shows the children who have received weekly versus daily growth hormone. What is the pattern of IGF? You see, definitely the IGF Z score in the dark blue is slightly higher compared to the light blue, but definitely it is not a very significant difference. And this study very importantly used very standard validated tools to look at the improvement in quality of life and well-being, emotional well-being, which is severely compromised in a lot of children with chronic problems. And what is it they say? All assessments favor this molecule over the daily growth hormone injection. So I think this is very, very, very a very positive note that encourages to take up this molecule. And the most important one, this is an advantage over the previous molecule. The local site reactions has been very, very minimal. There has been very, very minimal. The injection site reactions are almost similar in children who receive the weekly versus the. Probably this is going to result in an improved adherence to treatment and maintenance of growth velocity. And so we saw the second molecule. Now coming to the third molecule. This third molecule is again developed by a different company, and it uses a different technology. What is the technology it uses? It uses a part of the human chorionic gonadotropin appended to the C-terminal, which is going to result in an extension of half-life. So what is it that it is going through? So now what does the data tell us? This molecule has been studied in two different large studies from Asia. One is a Japanese study and one is a multicentric study, which includes good amount of representation from Indian children as well. Look, remember the technology and usage of development of these molecules are different. So the doses are not going to be comparable at all. If you see growth hormone, we standardly use the same dose across whatever molecule the patient prefers. Here it's going to change, significantly change, because the technology of development of the long-acting growth hormone is different. Here the technology, the recommended dose is 0.66 mg per kg per week. Here this group, they studied the children more than 3 years, and the standard protocols were followed, and 24 Asian children have been included in this group as well. And the number of children who developed injection site reactions were comparable in those in the two groups. And as expected, you can see the improvement in growth velocity in children with daily versus weekly. You can see the two graphs, the light and the dark, they're almost comparable. And the mean treatment difference was only 0.3. And the somatrogon, which was administered, it was non-inferior to the daily growth hormone injection. So again, this third molecule also concurs with the previous two studies, saying they are good enough in terms of the growth velocity. And the other important things about the increment in IGF-1, what they noted was yes, as expected, the IGF-1 is slightly higher in the group which received weekly, but the difference was not relevant, was not significant. And 12 children in this whole group needed a dose reduction because of IGF-1. Probably clinicians who use daily growth hormone use oxology and IGF as probably if you're using the IGF daily weekly growth hormone, IGF has to be taken more seriously to avoid adverse reactions. And this is the Japanese study also on the same molecule, which showed a similar result. And this is a summary of the comparison of growth velocity in the three molecules. And you find that there is hardly any difference between the daily versus the weekly growth hormone. I think this is a very, very important slide where I have kind of summarized what the three molecules which are available or likely to be available in our country. The youngest age probably will be somewhere around 3 years of age, and probably up till 12 years of age. Most of them have included only GH-naive patients, and most of them have included only idiopathic or genetic causes. Post-intracranial SOL children were included in the first molecule, that is the LG group, but now currently it is not available. The doses are extremely different, 0.5, 0.16, 0.66. The local side effects are minimal in the two newer molecules, very high in the previous molecules. The antibody titer is very insignificant. I think that's a very positive note. Impact on quality of life is good. Indian representation in the trials are there. And the growth velocity, if you see all the three molecules, they're very much comparable to the daily molecules. And the slide, the part which is not missing is the Indian scenario. I think the first molecule is DGCA approved. That is what they say. Probably it's going to be available in a few days. The second molecule, I think it's on the pipeline. In the next few weeks, they say it's going to be available. And the third one, I think because of the local side effects and the poor take, probably we have to probably wait for some more time. So coming to the important question. Now, I think we are quite convinced that we are going to use long-acting growth hormone on children who have growth hormone deficiency. Now, what about non-GHT conditions? I think that's another big burning problem. 3 groups they have studied. Somapacetone has been studied in SGA. And the dose, as you can see, is as for your daily growth hormone. SGA dose is higher compared to the GHT dose. The somapacetone dose is higher in SGA. But again, they have very beautifully demonstrated that the height velocity and height SDS increment is similar. So the efficacy is proven, but the approval is awaited. But I think this would be probably next thing to expect, maybe after a year or so, that this molecule may be approved for usage in SGA babies. The second group is idiopathic short stature. So this probably may not be relevant for us. This is a Chinese molecule which was demonstrated in a very large study in idiopathic short stature, and they showed that long-acting growth hormone has a very good growth velocity in children with idiopathic short stature as well. But remember, we have to take it with a pinch of salt, but the technology is different in all the molecules. Just because this study shows that ISS grows so well, doesn't mean it can be extrapolated to the other molecules. We have to await the specific molecule trial in the specific study group. And this is the LB molecule which was studied in Korea on a very small group of children with ISS, and they said that it is having a good growth velocity as well. And Turner syndrome, I think this is probably one study which I could lay my hand on, and they said that the delta height SDS in long-acting growth hormone is comparable to those with weekly versus daily growth hormone. But it's a very small study, and it's a retrospective study. I think this, I would say, is like a yellow signal. Right now, we are standing at a point that maybe after we may be useful in our non-GHT indications as well, but we have to wait and watch. And the other trials are going on. And coming to the last questions, which child can take growth hormone? I think after going through all these studies, we can say that idiopathic prepubertal growth hormone children between 3 to 12 years, probably maybe the first candidate group of children probably we can start off with. How to shift my child who is on daily to weekly? Probably you should give the dose 8 hours after the last dose on a convenient day of the week. I repeat again, 8 hours after the last dose on a convenient day of the week. What age? Preferably by 3 years of age. What should a parent know? The new moieties are going to result in a new set of side effects. Can it push these children into acromegaly? Increased adherence is reported on motivated patients. So non-motivated patients, are we justified to extrapolate it? GH antibody assay, probably for that study, it was made available. On a practitioner's perspective, assessment of GH antibodies is extremely tedious. It's not practically feasible. Lot of side effects described with daily GH reverses with stoppage. Is it the same with weekly GH? That has not been answered. Screening for metabolic complications should be done more aggressively and more meticulously, because there is dyssynergy between growth hormone and IGF levels with weekly. So you give it, but be very careful. That would be the learning. Extra precautions, treatment and monitoring is similar, but site rotation has to be re-emphasized because of the long duration of side effects. The impact of GH on lipolysis, etc., is going to be there as well. Higher effects. So you are going to may see a higher incidence of lipoatrophy. Reinforce site rotation in every visit. Can be used in children with post-ICSOL. As I said previously, all of them were GH naive, except for the first molecule of LG. All of them have used idiopathic GHTs, not post-ICSOL. But having said that, we don't see a very significant increase in IGF set scores. That's what this meta-analysis said. So I think on a careful individual case-to-case basis, you have to take a decision. Role of IGF, very, very important. It is reflected that the pharmacodynamic studies have been done. They say take the IGF should be measured 4 days after the last injection. 2 SDs above on consecutive readings warrants dose reduction. I think I am happy to have completed on time. I just would like to put this slide as a take-home message, which probably all of us should know. And maybe by the end of this year, many of us in this group may be using these molecules. Thank you very much.
Thanks a lot, Hemchand, for a wonderful understanding with regards to long-acting GH. And I'm sure the way GnRH analogs initially were coming as daily injections, then they came as weekly, monthly, now 3 monthly and yearly. Same thing, we are going towards a more longer acting preparation. Yesterday, we talked about long acting insulin, weekly insulin also coming up. So I think this will make it much easier in that regards. We'll probably take the questions at the end of the session because the time is a bit of a limitation. We'll carry forward with the next talk. And the next talk, maybe while we are loading the presentation, that the chairpersons can have a few words if they want to add. Dr. Yashwant.
Thank you, Dr. Hemchand, sir. As always, marvelous. The thing is that this is in pipeline, and again, very soon we are going to use. So I'm very sure that it is going to increase the acceptability, because the people, as well as parents, as well as the doctors, both were waiting for that. And let us see how it is going. Thank you.
Thanks a lot. So we'll carry forward with the second talk, which will be by Dr. Yuthika. Dr. Yuthika is, all of you know her, and we don't need any introduction in her case. She is working as the director of Regency IVF, and she has been involved in a number of pediatric and adolescent activities. She was the first one to really start off a clinic in that regards. And she has been working with the Growth Society and being a core member on that. So we'll carry forward from there. And she'll be talking about a very, very interesting and important topic of adolescent gynecology and how it is relevant from a clinical perspective. So over to you, Dr. Yuthika.
Thank you, Dr. Anurag. Thank you, chairpersons, for having me here to talk about gynecology to the audiences who generally practice pediatrics and specifically practice pediatric endocrinology. Now, it's very important to basically talk gynecology with you all, because many of your patients actually present with symptoms that have gynecology as a differential diagnosis. And more often than not, we generally tend to miss on it. So the whole idea of talking gynecology to you is that by the end of this talk, you at least put gynecological differential diagnosis in your thought process. So many of the disorders that you see, like menstrual disorders, adolescent sexuality, hyperandrogenism, and gynecological pathologies, what I'm going to do is I'll just talk about 3 cases of abnormal uterine bleeding, ovarian cysts, and adolescent endometriosis, because that has a significant differential diagnosis in your presentations. So let us look at this girl. And also, I don't think so we need to talk about abnormal uterine bleeding. We've had many sessions about it, about amenorrhea, secondary amenorrhea. So nowadays, we've sort of clubbed all the irregular and abnormal bleeding into one terminology of abnormal uterine bleeding. Previously, we used to call it dysfunctional uterine bleeding, and that used to be very focusedly only catered to heavy menstrual bleeding. Right now, we know that majority of cases of abnormal uterine bleeding is because of anovulation, which leads to an abnormal endometrium, which leads to a bad period. Then there are definitely other causes which are gynecological pathology. So we will go on to them later. So basically, this young girl, 16-year-old, had short stature and anemia, severe anemia. She had an onset of menarche at 15 years, and definitely she had menorrhagia with regular cycle. So right now it's written here, so it's very easy to make the diagnosis. But unless you ask the psyche of Indian women and Indian female, they never talk about menorrhagia unless it is too late. So the most common misdiagnosis in adolescent girls is actually menorrhagia. It presents only after anemia becomes very severe. Because in our psyche, less period, the patient will reach the doctor very quickly. And heavy period, they'll think it's getting cleaned, good period, heavy period, they never reach on time. So that's why many patients have mild to moderate anemia for years together. But when it is really severe, gone out of hand, only then they reach. So when we write it here, it's very easy diagnosis. But unless you inquire actively, you will miss menorrhagia. So what are the pointers to menorrhagia? So if somebody is bleeding more than 7 days, bleeding with clots, if somebody wakes up at night because of the bleeding, misses school, social functions because of bleeding, and there are bleeding accidents. Now, these are very, very personal things. Unless you ask, nobody's going to talk about it. So it's very, very important. Associated anemia is a bit too late to diagnose menorrhagia. So menorrhagia, basically majority of cases it's physiological. Physiological menorrhagia is occurring due to immature hypothalamic pituitary axis. By the time they mature it and develop ovulatory cycles, usually it resolves in about 2 years, and it's because of anovulation. Majority, it's mild, but a prolonged sort of a situation, they can end up into severe anemia as well. Now, pathological cases, it could be a bleeding disorders. As much as 10% of menorrhagia patients have underlying mild bleeding diatheses like von Willebrand disease, idiopathic thrombocytopenic purpura, and platelet function defects. And usually they have anemia early onset because their menorrhagia is a bit severe. Significantly, they have a family history. The mother might have had a hysterectomy at an early age, or a history of PPH, or she also having menorrhagia. So it's quite common. They sometimes give a history of easy bruisability or petechial hemorrhages. So you need to look for that as well. Systemic illnesses, a chronic liver disease or a chronic kidney disease, all this leads to, asthenia and overall, hypothalamic anovulation. That leads to secondary anovulatory bleeding. Even celiac disease might sometimes not present with amenorrhea, but present with anovulatory frequent bleedings. So usually those patients have sick, have features of the systemic disease and growth failure. Again, gynecological causes like endometriosis, fibroids, polyps, malignancy, and infections can also lead to pathological causes. And last but not the least is the endocrine causes. Because endocrine is a very flamboyant branch, and majority of people, the Google generation, everybody thinks that a heavy period is they reach an endocrinologist, and that's why you will see the majority of burden of menorrhagia patients. So it's very important to look at all the other causes of abnormal uterine bleeding. But generally, patients of endocrine this thing are, well, they are not sick, they are generally obese, and they have the other features of endocrine disorders. So coming back to this 16-year-old girl, she had short stature and she had abnormal uterine bleeding. She had hypertension, and on workup, she was found to be having a kidney problem. So ultrasound was completely normal. So this was not a gynecological cause of, abnormal uterine bleeding. It was a secondary cause, and definitely it has to be treated by the pediatricians, because systemic diseases definitely lead to a chronic hypothalamic anovulation kind of situation that leads to menorrhagia, and correction of that disease, or maybe you will have to give them support for abnormal uterine bleeding to prevent further menorrhagia and correct her anemia. So key questions is you need to first confirm menorrhagia, and that's the most important part, because this is going to happen only if you ask. So that's, as I said, it's the most misdiagnosis. You can use PBAC charts, and I'll come to them later. Pointers, as I said, you have to ask direct questions. Secondary causes, generally, if there are chronic illnesses, endocrine causes, but gynecological causes, generally pain is the feature. If somebody is not responding to treatment, and if she's associated with pelvic pain, then definitely you have to involve gynecologists. So that would be one thing to go. So this second girl, she was a known case of celiac disease. This patient presented to our clinic, very regular with the follow-up. Since 8 years of age, she had celiac disease, normal growth, normal onset of puberty. Everything was up, completely normal, everything fine. And then she presented with anemia. The fellows thought of she's sort of become non-compliant, did the TTG, and it was still negative. And then it was, anemia was treated. And then later on, it was identified that she had an onset of menarche, she had bad periods, and that was overlooked. So assessment, the most important assessment is to ask for it. Ask for the period. If you have anemia in an adolescent girl, ask for her period. That's the only take-home message that I want. And when we asked, it was pretty clear from her history itself that her anemia is because of the heavy periods. And if somebody is borderline, you can actually do an objective test, which is called the PBAC chart. It's all available on the internet. You can give them these pictorial charts, and the score of more than 100 is confirmed menorrhagia. Definitely, even in her case, there was no gynecological pathology. So any any patient in the first few years of her menarche can have anovulatory bleeding, and then that can lead to anemia. If somebody is prone to anemia, like a patient of celiac disease, that can occur even in, very early onset in physiological cases as well. So coming on to how we treat, it's a very busy slide. So I'll just, quickly, if somebody has mild menorrhagia and regular cycle, even tranexamic acid in a dose of 20 to 25 milligrams can control the bleeding and prevent menorrhagia. If somebody has, frequent cycles, anovulatory bleeding, irregular, prolonged bleedings, then you can add progesterone, which can be given to 3 to 6 months, but prolonged use of progesterone in that age group can lead to poor bone health as well. So that needs to be seen. If somebody has menorrhagia with infrequent cycles, so very infrequent cycles, 3 months period, and then the period is very prolonged, those patients better would be to give estrogen and progesterone combined pills or the OC pills. And then the other things are used for intractable cases like patients with kidney disease. We very frequently use DMPA and other cases. So sometimes you have a patient who presents to emergency with really bad bleeding and, severe menorrhagia, and you have to admit this patient, stabilize this patient, even give blood transfusion. In those cases, a very good regimen to stop bleeding is to give a high dose progesterone. Progesterone causes healing of the endometrium and stoppage of the bleeding in a dose of 50 to 30 milligrams in the first 2 days, and gradually tapering it to 10 milligrams, 5 to 10 milligrams for the next 20 days, and adding tranexamic acid. Now, all this is present in our chapter that we published in IAP textbook of gynecological disorders for children and adolescents. So when to refer to the gynecologist? Whenever there is pelvic pain associated. Pain is a very significant feature. Again, in the Indian psyche, we want our girls to, bear the pain. So generally women will not talk about it unless you actively ask, do you have pain? Because pain is regarded as something that usually occurs. So they will, unless it is unbearable, they will not talk about it. It's very important to ask pain. And if there is a pelvic mass, so usually in all girls with abnormal periods, we generally do a screening examination. So if there are uterine masses or ovarian masses, that's the time when you have to refer. And if she is non-responsive to progesterone, sometimes the endometrial hyperplasia is so much that even if you give progesterone and the bleeding doesn't stop, sometimes they could have a polyp, or even I have seen patients, especially obese patients with menorrhagia, with actual endometrial hyperplasia and even very early onset endometrial cancer. So that should not be overlooked and should be properly evaluated. And if there is a sexually active teenager, because then there's a chance of pelvic inflammatory disease happening, especially chlamydia, that is leading to all these problems. So you involve your gynecologist if these 4 things are found in your patients of menorrhagia. So coming on to this second case of ovarian cyst in young girls. Now, this is also a very common presentation to endocrinologists. 1 episode of vaginal bleeding, very, early onset, thilarchy, normal for height, for the age, the height and weight, everything is normal. And the ultrasound shows a simple ovarian cyst. Now, what I call simple ovarian cyst is generally something which is thin-walled, clear, without any septa or solid bodies, unilateral, and not associated with any ascites or fluid. So a simple ovarian cyst in this setting, how to approach this child. And I know we've gone through these sessions. Basically, any ovarian cyst in a young person or in an adolescent girl could be physiological or gynecological, pathological. Non-functional cysts are very common in pubertal girls, very uncommon in prepubertal girls. Functional cysts sometimes can happen in prepubertal girls. So functional cyst would be, which is producing estrogen. Benign, so neoplastic benign or non-neoplastic benign cases and malignant cases all are found in ovarian cysts. So follicular cyst or corpus luteum cyst is so common that it can be overlooked if it is not very large. The adolescent girl with a small non-functional follicular cyst or a corpus luteum cyst is a benign thing. And very commonly, you have patients who come with an ovarian cyst. So you just follow it up and it resolves on its own. Follicular cyst in a prepubertal girl, and especially in the kind of presentation that we had, would be because of hypothyroidism, or a part of McCune-Albright syndrome, or what we say that the partial McCune-Albright syndrome, which is only located towards the ovary where they have recurrent ovarian cysts. Now, these are associated with peripheral precocity or an isolated vaginal bleeding. Benign cysts, you can have chocolate cysts, dermoid cysts, teratomas, which are solid. They generally are associated with pelvic pain because they grow very quickly. And then you have the malignancies, which are associated with all the other features of malignancy. They are large size and they have complex in nature, usually bilateral, associated with solid areas and all those complex features. Now, key questions when you have a girl with ovarian cysts is what is the pubertal status and how is her estrogenic status, which we can look at, look at the vaginal mucosa, because sometimes it is so little that only a temporary thing happens. And then you look at the growth, what is the bone age? So in hypothyroidism, bone age is usually retarded. In McCune-Albright syndrome, it is advanced. So it's a true peripheral precocity. And then the pointers. Now coming on to this girl, she had a very little, rise in estradiol, but her FSH and LH, so showing towards peripheral precocity, normal bone age, no hypothyroidism, so functional follicular ovarian cyst. Now, in this case, generally what happens is that that this one will resolve. So you have to keep her in follow-up. The only thing that we need to be sure of is that sometimes these ovarian cysts can have torsion. So this needs to be, really followed up. Patient needs to be explained that if she has any pain. So as I said, gynecology needs to be involved if there is pain. So if she has any pain, then that needs to be settled. Otherwise, this will resolve on its own. And sometimes it could be a very early onset presentation of McCune-Albright, which is partial, which has recurrent ovarian cysts. So you need to follow these patients up to see how their puberty is progressing and how the cyst is going. Coming on to the 7-year-old girl. Now here you can see a very advanced puberty. Breast stage is 4, and she had already had Minaki. She had a large ovarian cyst. Now she presented to our gynecology team with a very large ovarian cyst and signs of, puberty. And we had all planned for laparotomy, thinking that this is a granulosa cell tumor of the ovary because she was really this thing, and not involved pediatricians. And then it was found that she had, she was hypothyroid. So basically, in the gynecology field, very commonly a large ovarian cyst is thought of neoplastic in nature, and we have a very huge tendency to operate and take it out because we see commonly neoplastic cases and hypothyroidism is commonly missed. So we need a sort of a combined care between the pediatrician and the gynecologist for this girl. So basically, we all know that a very high dose of high level of TSH acts on the follicle recepting, FSH receptors and leads to development of this thing. But the cyst completely resolves on correction of hypothyroidism and the laparotomy can be saved. So when to refer if you have a complex cyst? If these are bilateral, if they're associated with pain, the size is more than 5 centimeters, they're thick walled, there are internal septations and solid areas, those are the times we need to really involve the gynecologist, and especially time is up. So especially if there is pain, it could be a simple ovarian cyst spotting, or there could be infection happening. So pain needs, you need to really involve the gynecologist to rule out any organic cause of infection or neoplasia happening. Okay. So the last case that I was going to discuss was about adolescent endometriosis. Now, adolescent endometriosis I really want to talk about is because it is very frequently missed and it is diagnosed very late when there are complications of the disease. So endometriosis is basically a disease where the endometrium is implanting in abnormal sites. So ectopic endometrium. Usually the most common site is the pouch of Douglas, behind the ovaries, around the tubes. And usually when you have your cyclical hormonal changes, the endometrial glands glow And when the hormones come down, the endometrium sheds. But because this ectopic, there is a lot of inflammation in the area. You're able to